So, any question from the audience? There's another one.
What criterion do you use to have the good tests on the right place?
Who wanna take this question?
As we said, in fact, the emotional process, the metacognition, the executive function, the double task, the reaction time, the attentional process, and so on during surgery, according to what the patient asked to you before surgery. For instance, I had a psychiatrist 1 year ago, and he told me I want absolutely to preserve my empathy in order to continue to be able to deal with my patients. And then we incorporated specifically this task, and because it was a right temporal tumor, into the contact of a ventral semantic pathway. Once again, how do we know where we are? Because more and more we have understood the principal basis of the subcortical connectivity according to these functions, supramodal functions beyond language.
Well, you can't do all the tests on a specific place. How do you select the tests? Do you do one test on one place or whatsoever?
Once again, we are doing two tasks simultaneously most of the time, but I spoke about the right IFOF, for instance, because I'm sure we will speak about that during the talk the session dedicated to the insula, especially in the right non-dominant hemisphere. If I am into the contact of the IFOF, because you know that more or less according to your knowledge of the structural anatomy, dissection you did yesterday, if the mentalizing task is negative, you can do the PPT. If it's negative, then you can remove more. But most of the time, you will have at least one which will be positive. So we should know where we are. I don't know how to explain more the fact that this connectivity, this minimal common brain, and not related to the cortex itself. The cortex is very plastic, finally.
I think we are learning more and more. And for example, recently I operated in the right temporoparietal junction. And after the surgery, and even 1 year after the surgery, the patient is totally unable to perform the part B of the trail-making test. So I learned something, and I understood why. And for the next case, I will operate in this location. I will add the trail-making test part B if the patient needs it for his daily activity. But I think that the more we will report and the more we will look at the post-operative testing of the patients, the more we will improve the testing and the quality of the results.
You and thank you to have post-operative MRI and fMRI. Definitely, I'm not against fMRI and DTI because I was probably one of the first to use it 20 years ago, trained by Bernard Mazoyer, but outside the operating theater. And to learn, as you said, in fact, we should have cognitive assessment before and after in order to be objective and for the quality of life of the patient and to do a tailored rehabilitation. But we need also pre- and post-operative functional imaging. And then suddenly you can learn so many things, especially with the new tools, theory of graph and so on, the Bayesian model, the small world theory. And if you have a good guy around you, I'm sure that you will explain many things about neuroplasticity visible now thanks to longitudinal functional imaging, then you can learn more and more very quickly about this functional connectivity related to what you did by yourself, transitorily or permanently.
Okay, this is a general question. I would like you to speculate a little bit, because even though we believe deeply in connectivity and in plasticity, I would like to know where the limits are for this plasticity and this connectivity. I mean, we all know that occipital cortex is engaged in vision, right? But deaf people, if they don't use it, they can recycle it. But at the same time, there are, you know, usually we don't see that people use frontal regions for vision, right? So there must be some kind of compromise between connectivity and plasticity and the limits, right? So I would like you to speculate a little bit about that.
Probably we will speak about that with especially Emmanuel, the input-output. If you cut, of course, you will induce a permanent deficit. Speaking about the calcarine fissure or the optic radiation, if you cut them, so you will induce a visual field deficit and the patient will not recover. But he can recover a normal life if finally he has a compensation. Speaking about the strategy and the spatial awareness, if he agrees to not be able to drive anymore, for instance. So you see, you have just to say to the patient, this compromise, and some patients told me, especially in Paris, in fact, because in Paris they can take subway, while in Montpellier it's much more difficult, and most of the time they are telling me I need to drive 20 kilometers every day, so I cannot accept to have hemianopsia. So that means that I induced voluntarily one hemianopsia in Montpellier for 10 years now, while in Paris I induced approximately 10 voluntarily, because they told me finally I didn't care, typically. Plus, of course, the connectivity regarding the higher integrated, sophisticated function, and then more it's sophisticated, more you have plastic potential finally, if you agree to induce also increase of reaction time. So you should explain that to the patient. I think you have the same experience.
Hello? Okay. I would like to move the discussion on screening test now, if you don't mind. Which is very important. It's something that has never been done in other brain disease. And I would like to ask you two things, Emmanuel. First is, do you have something to learn from other programs in other tumors, like breast cancer, colon, etc., etc.? And the second thing is, what do you think will be the next step in practice?
Okay. Is it working? No, it's not working.
It's for you, yes.
The micro is working?
No, it's working.
Yeah, it's working. Okay. Regarding experience in other pathologies, I don't have any contact with any other program. I know that in France, at least, for breast cancer, gut cancer, and prostate cancer, the attendance rate is very high. It's close to 90%. So I know that this program are running very well, but I don't have any idea about the real benefit that we can gain from this program. And I know as well that there has been, for breast cancer recently, there has been quite of a controversy in France regarding the periodicity of the screening, but that's all what I know. And for the brain screening, I think that the next step is to set up a project to evaluate the sensitivity and specificity of automated tools of brain MRI analysis. That's really the next step. If we cannot solve this problem, there is no hope to launch any screening. And I think that with the biobank project, they will have these huge databases, 100,000 MRIs from, I think, 30 years of age until 60 years of age. So I think that there is some material, but we need to annotate these MRIs. So we need to review all this MRI and to say it's normal, it's abnormal, it's normal, it's abnormal. You know, like Google, when you, sometimes there is some testing, they ask you to find the cars in the different images. That's more or less the same we should do. Is it normal or abnormal, normal or abnormal? And we need maybe, I don't know, maybe 10,000 annotated MRIs, and then we can test the algorithm. And also, at the same time, I think we need to define what we want for habilitating a center to perform surgery in a screened patients. Because I think it really requires a huge experience. There is a risk that if we do the screening, the patient will be screened and it will be operated not in a good environment. So we don't want that.
Technical question. My first technical question is, which is the indication for surgery? Because in incidentalomas, in patients asymptomatic, we must distinguish between the symptomatic of asymptomatic. I am asking about the indication for surgery and which type of surgery for these patients asymptomatic, incidentalomas, in other terms. And which type of surgery for Professor Duffau?
As we said, in fact, first of all, you have to demonstrate that the patient is really asymptomatic. If you do a very extensive neuropsychological examination, you will demonstrate in more than 50% cases that they are not asymptomatic. Second, of course, to do several MRIs to demonstrate that it's not a stable imaging, because we are not completely crazy. If the patient is really well and if the imaging is perfectly stable, we will not propose surgery. But if the tumor is increasing, you know that it's a tumor, and then, of course, we will propose surgery, but awake surgery in all cases, to my opinion, in order to be more sensitive within the brain, according to the discussion we had before. I mean, to map more functions and to learn more also in order to increase our reliability and maybe to become quaternary, as you like to say, center, and not just to do one awake surgery every 4 months, because otherwise you have not this level of reliability. Not speaking about the surgeon, but the team, the anesthesiologist, the neuropsychologist before, during, and after, the rehabilitator. Recently, for instance, I said yesterday evening, I operated on for the first time in my life a patient with intentional discovery of a diffuse low-grade glioma, because the father and uncles died from a glioblastoma. He said, I want absolutely to benefit from an MRI. And if you discover something, I would like to be operated on. And we found the low-grade glioma. We waited 3 to 6 months because he said, I am completely crazy knowing that I have this. I have seen my father. I would like to be operated on. And we did a supratotal removal, a real frontal lobectomy. And it was a low-grade glioma, definitely. And we did nonetheless, and this is the major issue probably in this history, a post-operative rehabilitation while the patient was well before and after surgery. And 3 months after, I know it's difficult to believe, but the patient was better in comparison with before because he's young, and in fact we pushed the brain plasticity. So to me, quaternary department means that we should have a post-operative rehabilitation, at least to coordinate this rehabilitation, if not done directly in your department, in order really to improve the quality of life. To me, it was not on your slide, but it's absolutely crucial to be able to coordinate a rehabilitation.
Yeah, it was because I insisted on the fact that the environment should include speech therapists, neuropsychologists, or it was.
Yes, but no, because it could be a little bit too passive. I mean, just the assessment before and after, to speak the same language, to be objective, and so on. But in fact, no, to be active and to rehabilitate even normal people, because they can improve.
Thank you for sharing your experience and knowledge. It's always been mentioned that post-operative deficit, they tend to, most often, they tend to improve at 3 months, 6 months. Is there any predictive factor, either positive or negative, that you use for understanding whether or not the patient will improve? I'm thinking about the onset of the deficit after surgery, or specific sequences you use at the MRI, or a threshold in neuropsychological tests done after the operation. Thank you.
Invasion of the white matter tract, I will say, first of all, like the almost last slide when I said if you have an invasion of the I4 already before surgery, you know that the recovery will not be optimal by doing a classical left temporal lobectomy according to functional boundaries. Second, I think we should be humble regarding that and to collect prospective data using the serial imaging. And Jérôme Cochereau can explain a little bit more that we are doing now more and more resting state prospectively, just in order to compare before and after surgery what we did during also the transitory worsening. Very frequent, we did not speak maybe enough about that, but of course we explained to the patient you can have a worsening for a couple of weeks, so rehabilitation in this case without any discussion. But now, after SMA syndrome, for instance, you are able to obtain the resting state by asking to the patient to do nothing. And then, after recovery, and just to analyze these serial events in order to probably one day start to identify some pattern of reorganization before, just after, and after surgery and after rehabilitation. And then we will be able to predict. I mean, to my opinion, so it's a little bit too early. As I said, I cannot predict at the individual level if the patient will improve or not. But we are working on it. And I'm sure that in 10 years, we will be 90% cases able to say you will have 10% of deficit or maybe to improve in comparison with before surgery. I think you are doing more or less the same thing.
Yeah, and I think that age is definitely an important factor. I think for what I observed, after 50, 55 years of age, the delay for recovery is more 1 year and a half, rather than 4 months for younger patients. And also probably the small strokes are important to consider. I think that that's the real limitation of the functional surgery. Inevitably, you will cut some deep perforators running in the depth of the sulcus, and this can lead to an involuntary stroke, and this can limit the recovery in some cases.
Regarding the relationship with the patient, that doctor that didn't come back again to the consultation anymore. And my question is, how do you manage the communication with the patient regarding this news that you are commenting them, and how they respond to this notice, this news regarding they have a tumor?
Well, you mean for the Oli Mafucci patients? When we found something on the MRI, we told them before that if there was nothing, the MRI would be done 3 years later. So we told them that we will screen every 3 or 4 years. And so when there was something, I told them I have a doubt, and we will do the next MRI earlier than 3 or 4 years. We will do in 6 months or 1 year.
Maybe another much more emotional issues, I mean, speaking really with the patient, is that when they know they have a disease, because sometimes probably you had exactly the same patients with incidental discovery of low-grade glioma many years before to be referred to your department. Mm-hmm. And finally, because we are telling more and more that, the patient can come by himself or herself. And it's not infrequent in my experience that they are telling, you know, before surgery, I was not able to enjoy normal life because I knew that I have something in my brain, and finally the psychological issues were much more important rather than to be operated on to take maybe a risk, because we know that risk zero does not exist, but now to know that you remove the tumor. And even if I'm not sure I am cured, because you were honest by telling, okay, we have not enough follow-up, I feel better now, and my quality of life is subjectively improved following resection of an incidental diffuse low-grade glioma while I was asymptomatic, because in fact, now I feel better. Just subjective feedback, not just one patient, but I would say in 1/3 of patients.
Yes, but the problem of the question, I think, is that you are not sure that it is a glioma in the cases I presented. So this is different because you tell the patient, okay, there is something not really normal, but it's not for sure a glioma, so we have to wait a little bit more. Yes. So this is not so easy psychologically for the patient to accept that the MRI is not normal, but it might be nothing as well.
Yes, but you know that if it's stable, we said also in front of the academy that we should be connected to neurologist. I mean, to refer maybe to neurologist involved in inflammatory disease or vascular disease. And then the management will be a little bit different if we started to have a stable, real stable imaging after 1 to 2 years, because I had some patients like this. Sure. And I think it's not good for them to continue to be followed by a surgeon waiting for doing the surgery, but by a medical neurologist. So it should be a network.
Starting with treatment for the glioma, but as Emmanuel showed in his slide, the incidence is so low compared to all the other findings that you will do. For instance, the colloid cyst, the meningiomas, the multiple sclerosis patients, and not all of them will face the start of a treatment and may have become real worried by that MRI. Shouldn't we be looking for liquid biopsies, for instance, to look into thrombocytes to find specific molecular profiles of gliomas instead of the MRI scan?
It depends probably on the patient, but I mean, this discussion is important to me before to have the MRI. Because now, to be honest, more and more, I have the family of patients I operated on asking this question. Is it mandatory to me to benefit from an MRI? And the question is not after discovering something else, and maybe not a glioma, but before. You know you have a risk. Maybe we will find an imaging. Maybe we will not be able to tell you it's a glioma, I can remove it, and so on and so on. So what do you want before? It was exactly the choice given to the patient, to the human being, I think, before. And of course, to answer, in fact, your more technical question, we would like to find something in blood, definitely. But we are working on it. We will try to publish a paper by telling today. It does not work because we have tried RNA and so on and so on. I would like to believe on molecular biology regarding that because finally it could be helpful, but it's not efficient in low-grade glioma. In glioblastoma it was described a little bit, but not in low-grade glioma. But we tried. I don't know your experience about that, but for us today, zero.
Yeah, still, I would be worried. You're not only treating the patients that you identify, you have a responsibility for a normal population and all their discoveries. And that's, I think, something to think over. At least team up with other experts on all the other pathologies that will be identified. As Emmanuel is clearly advocating to have quaternary centers to send these patients to. For the gliomas, we may have quaternary centers for multiple sclerosis identifications and meningioma findings as well. Okay.
But we agree with that. It's exactly what we said in front of the academy. And this is the reason why we went to the academy with Luc Taillandier, neuro-oncologist, but also connected. It was not totally hazardous with one of the best, at least in France, neurologist involved in multiple sclerosis, with a network. But we discussed all together through Luc, and his colleague said, but in fact, we would be very happy also, speaking about multiple sclerosis, to benefit from earlier diagnosis, because we are proposing more and more earlier treatment. So everything is in fact now working on the same way to be preventive within the brain, finally. Makes sense, because limitation of plasticity otherwise for multiple sclerosis, vascular disease, and so on.
I have another question. What strikes me if I talk to these patients after surgery, that, as you told us, normally they do very well on all these neuropsychological tests you give them. But on the other hand, and quite a few of them report complaints like fatigue or concentration difficulties. So there's quite a discrepancy between the subjective complaints of these patients and what we measure. So my first question would be, is that also your experience? And the second is, what is the mechanism? And can we also avoid these subjective complaints that limit these patients in their normal life?
I think it's very interesting what you did, Jérôme, because speaking about the incidental diffuse low-grade glioma patients, we did both before any treatment, I mean the neurocognitive assessment, but also the subjective evaluation by the patient himself and the family. And finally, both are more or less linked. I think in 90% of cases, when they felt that they were not totally normal, we found something on the cognitive scores. In other words, I think that the patient is able, the human being, to feel that he has some attentional disorders, memory disorders, and so on, and tiredness, as I said, while he's young most of the time. We proposed, of course, we did not say that enough, maybe, the screening between 20 and 40, not 60-year-old, maybe. We will do that one day, but initially is in the younger population. And how to explain is probably this more sophisticated, not networks now, but interactions between different networks. And speaking about our work regarding much more cognitive neuroscience, we have the habit to say that we started to understand a little bit each subnetwork. Of course, we have not understood everything, but the most exciting is to see their interaction evolving online. Just now, what we are doing, speaking about a little bit our knowledge already, the fact that you know part of the talk, but new ideas, the emotional process according maybe to our culture because we are not from the same country, and so on and so on. And then we have a modulation of our brain, and this is what we would like to understand. And I hope that definitely this evening, this afternoon, we will learn more about the new methodology in functional imaging without a priori. I think it's, to my opinion, the possibility to answer your question, no a priori, to see the interaction between different subnetworks. And I'm sure that it will be coherent with the subjective view of the patient. Now, to be complete, I continue to follow, as you know, the patient by myself also, not only to be objective, but even with 10, 15, or even 20 years of follow-up. And we started to say, do you regret, finally, your life, the past 10 to 20 years? And never a patient told me, I regret. My problem is that my patients are not dying too much. I have too many patients now. It's really a problem if you want to follow by yourself also, because I would like to feel this subjectivity. I understand perfectly, beyond the scores. The problem is that to be completely in agreement with yourself, as I said at the end of the talk, you're not sure 3 months following surgery. You need to wait 10 to 15 years to have the feedback by the patient, subjectively. And now you know that you did the good or wrong job.
Yeah, Professor Duffau, you just showed some cases where you had supratotal resection, there were anaplastic foci in the low grade. So you propose not to have adjuvant treatment. But in the series of the French group, just 80 patients on 1,000 and complete resection. So it's much more common to not get a total supratotal resection and to leave some foci of invasion of the deep white matter or whatever. So in that case, how do you actually treat the patient? Do you follow them, propose chemo? No radio as far as understood, but...
It depends, in fact, on many parameters. First of all, the preoperative growth rate. If the tumor is growing fast, even if the lab is telling me, don't worry, I will be worried, because the tumor is growing fast. But most of the time, it's not done before surgery. And we lost information. Second, once again, the neuropsychological examination. If the patient is not well before surgery, due to the invasion of the connectivity in a tumor growing fast, you have a problem, and you will leave residue. And even if the lab is telling you, don't worry, of course I am worried, because the patient will not completely recover because I left in the connectivity and because it will continue to migrate. So very quickly, probably, we will go to the chemotherapy to avoid to irradiate this connectivity, otherwise the patient will have a decline of cognitive function very likely after 5 to 7 years. Third, it will finally depend also, of course, on the histomolecular parameters. I don't say that they are not interesting. I say that they cannot explain everything. And then the heterogeneity. But the most important to me is to try to refer the lobe, more or less, if possible, sometimes it's not within the insula, to the lab. And then to see if you have very aggressive part of the tumor, even sometimes glioblastoma-like, just in the middle. And if you did almost complete resection, not speaking about supratotal resection, but with the periphery, which is a low-grade glioma, maybe you can wait, especially if the kinetics was very slow before surgery and if the patient is well, because you have more or less nothing to lose if you are doing, of course, not MRI every 6 months, but every 2 to 3 months initially. And the reverse, sometimes it's not glioblastoma-like, but you have microfoci of anaplastic transformation, just transformation everywhere in the tumor. And if you left within the I4, for instance, you know that this tumor will continue to evolve against the quality of life of the patient. So you see, in fact, it's a dynamics according to many parameters based on good science. And my problem is that in recommendation, most of the time, you have just one parameter. But it's not a scoop. Catherine Doba-Duport said that 20 years ago, and she was right. Even if finally 90% of neuropathologists hated her because she said, you remember probably, you should also see the MRI and the patient. Integrated view. And now they use the term integrated diagnosis based just on histomolecular. It's not my opinion. This is just facts. It's terrible. They never saw a patient in their life, and they would like to explain to us what we should do without cognitive assessment, without kinetics and imaging, without the extent of resection. It's crazy. Because we are telling yes. We're accepting that more and more. Sorry, I have not understood. Yes, but evidence-based medicine is not based on this proposal, case by case. It's just a prior protocol. How you are doing in US?
So obviously there's data that supports.
I think you have to turn it on. That's it.
Can you hear me? Hello?
It doesn't work? Yeah.
Can you hear me now?
No.
So there's obviously data, prospective data, that supports using adjuvant therapy and radiotherapy for certain categories of low grades, quote-unquote high-risk low grades. I think what Professor Duffau is alluding to is the fact that those studies use a very narrow set of criteria for evaluating the overall impact of the therapy. And so when you have a patient where you know there's going to be, for example, a detrimental quality of life impact, neuropsychological impact of those treatments, you have to weigh that against the potential benefit that the treatments might provide. On top of that, you know, the story is incompletely written in terms of the value of adjuvant therapies for low grades. And there's also data out of San Francisco and other centers that suggests that for certain types of low grades, it may accelerate the mutagenic process and accelerate the tumors towards a transformation event. So I think we agree it has to be evaluated on a case-by-case basis, and you have to understand what the upside could be potentially in terms of tumor recurrence control compared to the downside of the long-term effects of both radiotherapy and an alkylating agent like Temodar. we tend to, at our center and at the Barrow, we tend to try to avoid adjuvant therapy at all costs, which means being aggressive surgically, which means being extremely ambitious with the schedule of surveillance MRIs, and also being aggressive with reoperation.
Thank you. Yeah, my comment, I'll be back on the definition of the supratotal resection. On the conceptual approach, supratotal resection is what you can remove beyond MR-defined abnormalities until reaching boundaries that you define preoperatively with the patient thought and expectations. But to translate this conceptual view on a more practical approach and on your post-op MRI, we define supratotal resection by an amount of resection outside the MRI-defined abnormality. And in several patients, we have a very small safety margin between the glioma and the resection, and in other one, very large margin of resection. So possibly that's the same on the functional outcome and quality of life, because you did as much as you can for the patient, but that's probably not the same on an oncological outcome. So in my own practice, I decided by myself that a supratotal resection is a safety margin of at least 5 millimeters. But that's not a rule, and possibly we have to define better what we call what is a supratotal resection, for example, to translate better and clearly on our works and publication.
I think Emmanuel can answer, because I would say, why 5 millimeter? While probably you can, thanks to your model, try to understand by using several MRIs before the treatment, if you have much more an invasive pattern or much more a proliferative pattern. And in some cases, maybe with 4 millimeters, you cure the patient. And sometimes with 2 centimeters, you will leave nonetheless tumoral cells. So my question is, now with the new model, can you have a better prediction about not only the growth rate, I think we have really understood, but the proliferative versus invasive pattern in order to predict the real impact of supratotal removal in this patient for the long-term follow-up?
Yeah, and the answer is no. Simply because the MRI imaging is not sensitive to 2 different thresholds of cell density. So this is the main issue. We don't have any imaging modality which can tell us this is a threshold of cell density and this is another one. So unless we can solve this problem, there is no hope that we can address this question. And also there is another problem with supratotal resection, is that I found it quite difficult to be homogeneous around the tumor, to have this margin of 1 centimeter, for example, all around, because if you find the margin, the functional margin, 5 millimeter in some place, there is no need to remove 2 centimeters in another place. So I find it difficult to find the minimal distance, the maximal distance that you can reach for functional reason, and to keep this distance all around the rest of the tumor.
Can the intraoperative MRI solve this problem?
Can the intraoperative MRI solve the problem of this margin around the tumor in the supracomplete resections?
So my question is, what do you prefer? The technology or your experience as neurosurgeon?
Not the technology, not my experience, just the feedback by this patient at this moment, case by case. So for me, it's solved. But to answer your question, I cannot see the limit of the tumor, of course, beyond flare before surgery, but I can start, as I said, to see the functional boundaries, to anticipate that in the patient, and to say, finally, I know that I can take, for instance, 2 centimeters in front of the tumor in the premolar cortex, but just 5 millimeters posteriorly. So I anticipated that probably the margin will be 5, the minimal 1, and then I will take just 5 anteriorly, but not more, even if I can do 10 tasks and they are negative, because why to remove normal brain too? Okay, I totally agree. But I'm surprised because I thought that thanks to diffusion imaging, Lorenzo started to say, finally, maybe we can predict a little bit more the extent of the tumoral cells migration beyond what we can see on FLAIR. That's true or not? No interest. Definitely no interest of intraoperative imaging. Except if we are lost in the brain, it's another problem.
Yeah, I think the intra-op MRI is going to have the same limitations as a preoperative in terms of sensitivity. One of the challenges with the concept of supertotal is that it's predicated partly on functional boundaries, but also partly on the imaging sensitivity itself and what a FLAIR image represents. I think one thing that we have to consider is modalities that measure cellular tumor burden beyond imaging criteria. So things like fluorescence, things like Raman spectroscopy, modalities of imaging that are not just predicated on MR imaging, because what we're talking about is reducing the tumor burden at the margins to hopefully a clinically insignificant level. So when Johan chooses 5 millimeters as that margin, you know, there's a lot of assumptions that go into that that may or may not be true, but the reality is that the biology of these tumors is not homogeneous, and so some areas may have more extensive microscopic infiltration than others, and the MRI and the FLAIR will not detect that. So I think as we push the boundaries of extent of resection, we have to redefine what we want to use as our metric for extent of resection. And currently, I think we're getting to the limits of what MR imaging will tell us about what really is a residual disease.
I have a conceptual question for Dr. Duffau. You showed us that at the cortical level, brain works like a network, so localization is no more an answer for the brain functions. But it seems in your presentations that at the cortical level, there is not a clear localizationism for brain functions, but at the subcortical level, what we find is the contrary. There is a real localizationism for subcortical pathways. So how can you explain this disagreement between no cortical localizationism, but on the other side, a strong localizationism for brain functions at the subcortical level? How?
It's not a localizationism in the depth, it's just an anatomical constraint. I mean, you have like a fan, and of course, if you cut a part of the fan cortically speaking, you have U fibers allowing you to compensate. But finally, because you have a convergence of fibers due to the fact that you have the deep brain nuclei, the ventricle, and then everything now is within the same 5 to 7 millimeters, of course, you have a higher risk, in fact, to disconnect a major part of the brain when you cut just 5 millimeters more. You see, in fact, we should imagine that it's not just 5 millimeters in the IFOF, but that you are going to disconnect probably the prefrontal lobe, the occipital, the superior parietal, the temporobasal, and so on. So this is the reason why I know that some of you came yesterday to do dissection. And more we should organize this kind of course, especially for young people, to understand that it's not localizationism, but when you cut a pathway, you should imagine the desynchronization of the rest of the brain and maybe the contralateral side. And to be honest, even for me, it's still complex to imagine what I do within the contralateral side, explaining why sometimes we are doing EEG online just to maybe answer the question, what we are doing in terms of prediction of recovery. Just to collect data. It's not localizationism. Please don't say that.
No, that's why I was amazed.
And I have a question for Nader. How would you envision a screening project in the United States, apart from the Brain Foundation project that will be presented later in the day?
Yeah, I think in the US, so I liked Philip's comments about the fact that a screening project like that is going to detect more than just gliomas. And I think actually you undersold the potential societal benefits because your calculations were based upon detection of gliomas. But in fact, you're going to detect early stage MS and other disease processes that I think have to go into the calculations to make the case. So I think if this was something we were to pursue in the United States, we would want to look at the societal, financial, and healthcare benefits of detection of anything incidental, and not just low grades. That being said, I think screening has a strong role for certain diseases in the United States, just as like it has in Europe, and we would have to pursue the same kind of channels for it.
Okay, so thank you very much to all the speakers, and we'll go for the coffee break.